Welcome to OffBlueMedical. Today we will discuss consent and capacity. So, informed consent is a formal communication between the physician and a patient regarding a specific medical intervention or a medical decision. So, this ensures the patient's autonomy in medical decisions. It is required before any non emergency medical intervention. So, in emergencies, consent is usually implied, and we will get to that in another slide. It must be voluntary, so you cannot force the patient to consent, and it should be understood thoroughly by the patient. So you cannot just give them a paper and tell them you need to sign this, and that's it. You cannot be protected legally against that. So you have to always inform the patient of their of the purpose of the intervention, of the risks and the benefits and alternatives. What will happen if they don't undergo, let's say, a medical treatment? What if they don't take the drug? What if they don't go with the surgery? If there is any other alternatives. So you have to always inform them and make it understood. You cannot just give them a paper to read and sign. You have to explain it to them. So, informed consent in vulnerable populations, such as children, here children cannot consent legally. It has to be taken from parents. You should always try to take their assent. So, assent is basically an informal agreement or like an informal consent when they are developmentally mature. So, around the age of 7 or 8, you should ask them, hey, can we do this? And prisoners, consent must be free of any influence related to their incarceration. So you cannot make them think that when you do this treatment, when you give them a treatment, or when you're doing a research and you tell them we have phase 1 clinical trial, so we need patients to test this drug. You cannot give them any influence that they might be released early on if they undergo this clinical trial. So always take prisoner's consent the same way you do with any patient. And in pregnant women, because this has risks to both the woman and her fetus as well. So you should always apply for institutional review boards. This is regarding research. So informed refusal in any medical decision, informed refusal, this is the definition of it. Informed refusal is where a person has refused a recommended medical treatment based upon an understanding of the facts and implications of not following the treatment. So it's the opposite of informed consent. This is informed refusal. So a classical case for this is, let's say a patient gets into a crash, sees breathing tubes, okay, and then screams, no tubes, and that's it. So do you intubate or not? Yes, you will intubate because the patient here has to actually understand what are the facts, what are the implications, what are the alternatives, the risks, the benefits. You have not discussed any of these with the patient, so you have to intubate in this case. So the physician responsibilities in refusal is always to ask why. So you cannot just say, okay, that's it, and you give up on the patient if they refused a specific medical treatment or a specific vaccine, let's say. You should always ask them why. You should ask them, why did you refuse this? Do you have any other beliefs? Do you have any other recommendations? Do you have any other suggestions? Do you have any other plans? And you should always reconfirm capacity. So a patient's capacity could be, and we will discuss capacity in this lecture. Patient's capacity could be different today, it could be different tomorrow. They might be able to make a decision today, they might not be able to make a decision tomorrow. So you should always reconfirm their capacity. Are they able to make a decision or not? And you should always document and write that they refused. So now we have to discuss decision-making capacity. Capacity is a clinical determination assessed by a physician, and it's different from competency. This is decided by a judge in a court of law. So you, as a physician, you determine capacity. You don't determine competency. Competency is determined by a judge specifically. So an abbreviation that I always use is going to be UEAR. You could also call it U-EAR. So UEAR, the U stands for understanding, E expression, A appreciation, and R reasoning. So understanding is the ability to comprehend the information provided by the clinician. So do you understand the diagnosis, the treatment, the risks, the benefits, the alternatives? Expression is the patient's ability to communicate a clear, consistent, and stable choice, either verbally, through writing, or through gestures. And appreciation is the ability to believe and relate the information to their own personal situation and condition. Reasoning is the ability to process and weigh the risks, benefits, and consequences to arrive at a decision. So you have to take these four criteria in mind. So a case is going to be a 35-year-old boxer who has a severe open fracture requiring surgery to prevent permanent loss of function. And his decision is going to be that he is alert, but he refuses surgery, stating that I'll be fine, I'm a professional boxer, I heal fast, a little ice and rest, and I'll be back in the ring next week. So here the patient clearly understands that this is a medical condition requiring surgery, okay, and he is able to express it verbally. But here there is no appreciation and no reasoning. He cannot weigh the risks, the benefits, and he doesn't appreciate the severity of this condition. So here the patient clearly lacks decisional capacity. So decisional making capacity, the hierarchy of decision making, first off, is going to be the patient themselves. So this is always the best option. If a patient has decision making capacity, then they should make a choice for themselves. They should take a decision for themselves. If they are unable to, for example, if they are in a coma, they lost consciousness, then we should always have a hierarchy. So we always take the patient's best interest. And this hierarchy is going to be, so the patient's decisional making capacity hierarchy, first off is the patient themselves, okay? Second off is going to be the healthcare proxy, which is basically a formal process where you designate someone to be your healthcare proxy just in case you lose consciousness or you go into a coma or what else. So an example is a 75-year-old male patient who is admitted to the hospital. Upon admission, they clearly know that his condition will worsen, maybe he will lose consciousness, so they ask him and he signs a healthcare proxy, which is going to be, for example, his wife or his daughter or his son. So this is a healthcare proxy. They will make the decision for the patient. The healthcare proxy is not determined through a legal process, through writing, then we take a living will or advanced directives. So this is basically a formal paper where the patient says, on a paper, they write like, I don't want intubation, I don't want cardiopulmonary resuscitation. It's a formal process. And then the last option would be to resort to the next of kin. So next of kin is also called the surrogate decision maker, which is going to be the patient's spouse, okay, the patient's spouse, then the adult children, then the parents, then siblings, then other relatives. So how do you memorize this? It could be a little bit hard for you because you have to understand this and memorize this in this sequence. So it has to be always like this. So if we take, for example, this patient, best who knows them is going to be their spouse, okay, their spouse, and then their adult children because they've spent all of their lives with their parents. Then their parents, the patient's parents, they also know them best, and then the siblings, the patient's siblings. So first off is always going to be the spouse, then the children, then the parents, then last off is going to be the siblings. And then if all of these are not available, then we take other relatives. So there is a note and it says the healthcare proxy, the appointed person always supersedes the next of kin. So if a patient's daughter is the proxy, her decision outweighs that of the patient's spouse. Okay, so for example, let's say an 80 years old male who has his daughter appointed as a healthcare proxy, he loses consciousness and she comes, his daughter comes to the hospital, says he doesn't want any more invasive measures such as intubation. Okay, and his wife also comes and says, no, intubate him, he wants to live. Do we go by the spouse, his wife, or do we go by his daughter? Of course, we will go by his daughter because the hierarchy specifically mentions that healthcare proxy supersedes, comes before the next of kin. If there was no healthcare proxy, if the patient's daughter was not the proxy, then we would say, okay, is there a living will? No. Next of kin. Which one is the first one? The spouse. Then we go by the spouse's decision. Okay? But here, the healthcare proxy is his daughter, so we go by her decision because she knows what's best. So how should a surrogate decide? So they should always answer the following question. What decision would the patient themselves would have chosen? If they do not know this question, they would try to answer what's in the best interest of the patient. Okay? So types of consent, there are many types of consent. The best type of consent is the written consent. Oral consent is harder to prove, but it's generally valid if it's heard by multiple people and it's repeated many times with the same decision. Implied consent in a true emergency, consent is usually implied. What does this mean? So this means the patient would have probably chosen intervention over no intervention if they had the choice. So a high-yield example would be an unresponsive patient who arrives in the emergency department after a major car accident. You can and should intubate and perform life-saving procedures immediately under the thought or under the principle that the patient themselves would have chosen intubation and treatment over no intubation and no treatment. So use of placebos, using a placebo deceptively, such as giving a saline injection for pain and calling it morphine, or a patient comes to your office, says they are feeling unwell, you just give them saline and you tell them I've given you antibiotics, or I've given you NSAIDs, or I've given you paracetamol, or I've given you painkillers. This is generally unethical. It violates the patient's autonomy and informed consent and undermines the physician-patient relationship and trust. You should never do this. For research purposes, patients must be explicitly informed that they are in a study where they might receive a placebo. You should also tell them what's their percentage of receiving a placebo. Like you tell them this study is going to be 50% interventional treatment, 50% control with a placebo, so you have a 50% chance of receiving a placebo.